So I'm going to be spending the next 30 minutes or so discussing airways diseases, both large airways and small airways diseases. And let's get right into the unknown cases. Okay, so what could this be? Slide on the left is inspiration. The slide on the right is expiration. Next case. 20-year-old patient. Okay, how about this CT scan? We see the recon on the left, and on the right side is the axial CT. Then here, I don't think this one should be too hard after listening to Dr. Webb's lecture. And the last unknown case. So take a look at that. Okay, so let's discuss airways diseases now. Okay, so I'm going to discuss large airways diseases, both narrowing and enlargement, as well as small airways diseases. Okay, let's start with the trachea. So tracheal stenosis. If you see stenosis of the trachea in its short segment, it's one of a few possibilities. Intubation or tracheostomy can lead to stenosis, scarring essentially of the trachea that causes focal stenosis. And once the tube is removed, then that stenosis remains. Wegener's granulomatosis can also result in focal tracheal stenosis, or it can also cause longer segment stenosis. But Wegener's can cause focal, and the rings tend to be thickened. Sarcoid can cause focal tracheal stenosis with a thick wall. TB can also do this, and a broncholith can also cause tracheal stenosis. How is that? Because a broncholith, as I said, is a lymph node that's calcified secondary to TB, and it erodes into the bronchus, and then that can cause scarring. And compression by a tumor can also cause tracheal stenosis. Okay, so what are we seeing here? Well, look at the trachea. There is thickening of the wall, and down here in the proximal bronchi is irregularity of the airway wall. Look how irregular it is. That's characteristic of Wegener's, to have irregularity of the wall. It typically is short segment, but it can be long segment. But if you see irregularity and thickening, differential diagnosis is Wegener's, amyloid, sarcoid, and infections such as TB or histoplasmosis. Those are the things that cause irregularity of the trachea. How about this particular case? Look right here. Look how narrow that bronchus is. So there's thickening of the wall, there's calcification in the wall, and narrowing of the bronchus. That is a patient with TB. Now, how about longer segment stenosis? When I say trachea, this also usually applies to the mainstem bronchi as well. So longer segment stenosis, relapsing polychondritis. This is actually a systemic disease which affects cartilage throughout the body. And patients can get ear pain, for example. That's the classic history. Ear pain because their cartilage in the ear is affected. So in this particular case, the wall is thickened. Now again, only the cartilaginous part of the wall. Amyloid can be diffuse or multifocal tracheal stenosis, can give you diffuse or multifocal stenosis. And tracheobronchopathia osteochondroplastica. I'm glad I said that. I stayed up all night thinking about that. Okay. So this particular disease, TBO, that's what Rick Webb told me, just say TBO. So TBO gives you nodules of bone and cartilage. That's very rare. It's really rare. And if you never see a case of it, I wouldn't be shocked. And if you don't know how to say it, it'll make me feel a little bit better. Okay. So anyway, relapsing polychondritis. This was one of the unknowns. Look at the tracheal wall. It's actually quite thick. And look at the marked collapse on the dynamic expiratory view. That's a characteristic. To have thickening of the tracheal wall of the cartilaginous part, the posterior wall is not going to be thickened because it's not typically cartilaginous back there. And you can see here the anterior wall is cartilaginous and thickened, the posterior wall is not thickened, and there's collapse on exhalation. And this is frequently treated with a stent if that collapse becomes functionally significant. How about this particular case? Look at the marked thickening of the trachea here in this particular individual, as well as thickening of the main stem bronchi. There is some irregularity, and there's also some calcification in the wall. So all of those findings are characteristic of amyloid. Thickening, irregularity, and calcification. You don't have to have all the findings, but this is characteristic. And look on the lung windows how much irregularity there is in the wall of the airway. How about this particular patient with TBO? Okay, so we see the trachea here. Look at the nodularity. These are nodules of bone and cartilage. So TBO, that's characteristic. If you see this dense area, nodules that are dense. Okay, that's the gross pathological look at this. Look at all these bone osseous nodules. Okay, that's it for tracheal and large airway stenosis. Let's move on. Let's move on and talk about tracheal widening. There's not really all that much that causes widening or enlargement of the trachea itself. Most common thing is tracheobronchomegaly, also known as Meunier-Kuhn syndrome. 95% of these individuals are males, and there's also dynamic airway collapse. So during exhalation, there can be collapse of the airway. This actually has been known to show up on the boards, even though it's pretty unusual. So tracheobronchomegaly or Meunier-Kuhn syndrome. Saber sheath trachea, what is this? This is actually elongation of the trachea and narrowing in the transverse dimension in elongation in the AP dimension. And what causes this? Well, chronic obstructive pulmonary disease, most commonly emphysema, causes a saber sheath trachea. Tracheoceal, which is essentially a little diverticulum coming off the trachea, and connective tissue disorder. This can also cause tracheal enlargement. So let's look at this particular case. So this is Meunier-Kuhn syndrome. This is enlargement of the trachea, and it's diffuse enlargement. Look how big it is. And that's it. Easy diagnosis, Aunt Minnie. Okay. Tracheal masses. 90% of primary tumors of the trachea are malignant. Okay, and these include Mucoepidermoid Carcinoma, Adenoid Cystic Carcinoma, and less commonly squamous cell or carcinoid. So actually the most common ones are adenocystic and mucoepidermoid. Metastases can also occur and involve the trachea. And what metastases, what primary tumors can metastasize to the trachea? Well, melanoma, okay, breast cancer, renal cell carcinoma, those are some of the tumors. So if you see a tracheal mass, what are you thinking? Could be a primary tumor such as adenoid cystic carcinoma, mucoepidermoid carcinoma, metastasis such as melanoma or breast cancer, or possibly a benign lesion like a papilloma. So laryngeal papillomatosis, this is actually associated with human papillomavirus, and about 5% of patients have involvement of the trachea. And what do you see? Multiple irregular filling defects. That's characteristic. So anyway, what is this? This is a mass in the trachea. Look how irregular it is. It's somewhat poorly marginated, and this turns out to be adenoid cystic carcinoma. So most common primary tumors of the trachea, adenoid cystic and mucoepidermoid carcinomas. Different patient. This is a patient, this is in the airway, but similar concept, squamous cell carcinoma. And you can actually see that right here, squamous cell carcinoma. A different person with a bronchial mass. This turns out to be mucoepidermoid carcinoma. How do we know that? Simply because of the pathology. Because it looks like any other mass, endobronchial mass. What other types of tumors can do this? Well, bronchogenic carcinoma, carcinoid, and then other tumors such as the airway tumors, mucoepidermoid or adenoid cystic. And how about this particular case? This is actually a pretty unusual case in which a mass, a thyroid cancer, is invading the trachea. So this is extrinsic tumor invasion by a thyroid cancer. And how about this little endo-airway metastasis? How do I know that's a metastasis? Well, based on pathology. You can't tell on this image. Differential diagnosis, bronchiolitis carcinoma, carcinoid, sometimes mucoepidermoid or adenoid cystic tumors can do this in the bronchus, or metastasis such as from what primary tumors? Melanoma, breast cancer, those are some of the more common ones. Okay, pretty easy. Let's move on and talk about bronchiectasis. This is defined as irreversible abnormal dilation of the bronchi, as opposed to normal dilation. Okay. The bronchus is larger than the adjacent artery on a CT scan, especially if you're looking on a high-resolution CT scan. What you're looking for is the bronchus and the adjacent artery, and if the bronchus, the inner wall to inner wall diameter of the bronchus is larger than the adjacent artery, that is called bronchiectasis. However, in patients who are over the age of approximately 55, the bronchus does tend to dilate even under normal conditions. So if it's just slightly bigger than the adjacent artery in an older individual, then we don't call it bronchiectasis. And the bronchus larger than the adjacent artery is known as the signet ring sign. So there are different types of bronchiectasis: cylindrical, varicose, cystic. Cystic bronchiectasis most commonly associated with cystic fibrosis. And let's look at this. This is the signet ring sign. There's the bronchus. Inner wall to inner wall is bigger than the adjacent artery, signet ring, in which that is the ring. That's the ring, and that's the bronchus. What's the reverse, in which the bronchus is normal, but the vessel is markedly enlarged, such as in pulmonary hypertension? The pulmonary artery gets large. What sign is that? Okay, so the ring is here, and there's a very, very large stone on it. That's the Elizabeth Taylor sign. Okay. So this is called varicose bronchiectasis. You see how tubular and what's the word, tortuous those bronchi are. So this is varicose bronchiectasis, and this is cystic bronchiectasis, rounded areas of bronchiectasis on the cross-sectional images, as you would see in cystic fibrosis. So let's take a quick aside and talk about mosaic perfusion. What does this mean? Mosaic perfusion means that certain parts of the lung are being poorly perfused. Why would that occur? Why would you get poor perfusion in certain parts of the lung? Well, there are two causes. One cause is small vessel disease. And what types of small vessel disease cause poor perfusion? Well, most commonly, chronic PE, chronic thromboembolism, can cause small vessel disease and mosaic perfusion. What do I mean by mosaic perfusion? Poor perfusion of certain parts of the lung, and that manifests on a CT scan as dark areas. So they're patchy, dark areas on the CT. That is mosaic perfusion. What is another cause of mosaic perfusion? I told you one cause is vascular chronic PE. The other big category is small airways disease. Now, why would airways disease cause a perfusion abnormality in the lung? That seems a little bit illogical, but it's not. It's completely logical, because airways constriction leads to reactive vascular constriction, because poorly ventilated parts of the lung are poorly perfused. So small airways disease also causes mosaic perfusion. So two major causes: small vessel disease, such as chronic PE; small airways disease, such as Bronchiolitis Obliterans, asthma, or hypersensitivity pneumonitis, or other possibilities like infection. Okay, so this is best seen on a high-resolution CT. We're looking for patchy areas of dark attenuation, of low attenuation. So the lucent areas tend to have fewer and smaller vessels. And the differential diagnosis, again, small airways disease versus small vessel disease. Okay, let's look at an example. Okay, look at this. This area is darker than this. And that area, this area is darker than this. Does everyone see that? Just look at the general appearance of the lung. This is all much darker than this area, and this is all much darker than this. And look at the vessels here. The vessels here are normal, but out here in the dark areas, the vessels are attenuated. That's how I know that this is abnormal, because it has attenuated small vessels, tiny vessels. And here, the vessels are bigger. Even along the periphery, the vessels are bigger than here. So this is mosaic perfusion. So differential diagnosis, small airways disease, small vessel disease. So air trapping is related to mosaic perfusion. What's the point of this? Well, on an expiratory view in high-resolution CT of the lung, we can look for air trapping. What's the point? Well, mosaic perfusion is due to what broad categories? Small airways disease or small vessel disease? How do you differentiate between small airways disease and small vessel disease? Well, small airways disease gives you air trapping on the expiratory views. Small vessel disease does not give you air trapping. So mosaic perfusion has two major causes: small airways disease, small vessel disease. And small airways disease, you will get air trapping on expiratory views. So geographic air trapping, meaning patchy air trapping, that is characteristic of small airways disease. If you see that small airways disease, it is not due to vessel disease. Okay, and this is an expiratory view. Actually, that was the inspiratory. This is the expiratory view. I think all of you can see that there are lucent areas here. It's quite evident. And these lucent areas are the trapped air. Why is it trapping air? Because the airway is abnormal, small airways disease. Air trapping indicates one of several diseases. The most important ones to remember: Bronchiolitis Obliterans, asthma, and hypersensitivity pneumonitis. You don't have to see any other findings. If you see air trapping on an expiratory view on a high-res CT, asthma, bronchiolitis obliterans, and hypersensitivity pneumonitis. Now, another disease, another common type of disease is small airways infection or airways infection, such as with cystic fibrosis, in which the airways are infected, or endobronchial infection. But you should see other findings with endobronchial infection. Okay, so cystic fibrosis, let's talk about that for a couple of minutes. It's autosomal recessive. They love to show cystic fibrosis cases on the boards. It's unbelievably common. Yeah, and I've actually seen the cases, all the possible cases. It's just unbelievably common. Okay, so Caucasians, unbelievably common on the boards, not in general. Okay, so it's most common in Caucasians in 1 out of 2,000 live births. Patients have viscous lung secretions and mucus, and it also involves other organs like what? Pancreas, for example. Infections are very common, especially Pseudomonas, Staph aureus. On imaging, what are we looking for? Cystic bronchiectasis, bronchial wall thickening. You can see plugged bronchi and air fluid levels, mosaic perfusion, and air trapping. So mosaic perfusion is patchy dark areas on the inspiratory view. Air trapping is what we call it on the expiratory view. And you can also see large lung volumes and fibrosis. That's pretty common or typical. Okay, this is a patient who has large lung volumes. Look at the anterior clear space, quite large, and fibrosis, and cystic bronchiectasis. And they're also patchy opacities. Let's see if we can see that a little bit better. Unfortunately, it's not projecting as well as I would like, but there is cystic bronchiectasis up here. It looks exactly like a board's case, right? It's way too dark for you to make a diagnosis. Okay, well, this is what it looks like on the CT scan. Okay, so we can clearly see bronchiectasis, bronchial wall thickening. Look how thick the bronchi are here. And do we see anything else? Do we see mosaic perfusion? Well, look at the darker area here versus the lighter area here. So there is geographic mosaic perfusion, and that, as I said, can be seen in small airways disease, including small airways infection, as you see in cystic fibrosis. So bronchial wall thickening and bronchiectasis and mosaic perfusion. How do I know this isn't cystic lung disease? Well, first of all, the walls are very thick. Usually in cystic lung disease, they aren't this thick. The other thing is you can often see branching, like as in this particular example right there, there's a branch. And you can see elongation. There's a branch right there too, and you can see elongation. Look how elongated that is. You don't see that with cystic lung disease. Also, you see these. Sometimes you can follow these from image to image, especially even on a high-res CT. You can follow it from image to image. Whereas with cystic lung disease, you can't follow elongated structures because there aren't any elongated structures. Same thing here. Darker area, lighter area. This is Mosaic Perfusion, and this is due to small airways disease, marked bronchial wall thickening, and bronchiectasis. And there's also nearly plugged bronchus right there. This is a plugged, very large plugged bronchus. Okay. With that, talking about plugged bronchi, allergic bronchopulmonary aspergillosis, this is associated with asthma. So they have elevated IgE, eosinophilia, and reaction to Aspergillus antigen. If you hear the history, eosinophilia, think that this is a possible diagnosis when you look at the images. So central bronchiectasis is characteristic, and classically mucus plugging, which is called the finger in glove sign, meaning that there are multiple branching bronchi that are plugged, and that can be seen on a plain film or on a CT scan. You can also get fleeting parenchymal opacities, meaning they appear and then go away. Okay, and this is a patient with central bronchiectasis. You can see that here, just enlarged bronchi centrally. You can see that again here. And this person did indeed have ABPA. That was the diagnosis. And this is not, this itself is not diagnostic, but if you see central bronchiectasis, that is in the differential diagnosis, especially in a patient with asthma. So history of asthma, central bronchiectasis, think ABPA is a possibility. And this is another patient. Look at the plugged bronchi here. This is mucoid impaction. And you can see here, this is the finger in glove sign on this reconstructed CT scan. Unfortunately, this person only has 2 fingers on the hand, but there is the finger in glove sign. So it's branching out of plugged bronchi. Okay, and what's really interesting about ABPA is that these patients can have high density mucoid impaction. So it almost looks like calcium, but it's just high density mucoid impaction in a patient with ABPA, and that's what we're seeing here, high density mucoid impaction. This is atelectasis, but the airway is plugged, and here also plugged airway. Okay, let's spend a few minutes on airways infection. I don't want to be redundant, but it's very, very important for you to know the differences between different types of nodule patterns. And Rick Webb, Dr. Webb went over that earlier with you. If you see nodules, it's not good enough just to give a random, or just a differential that includes everything. You need to narrow it down. Okay, in airways infection, most important diagnoses to remember are Mycobacterium avium complex, MAC. This is an atypical mycobacterium. Usually affects older women, but it can occur in men as well. TB and bronchopneumonia. So that is not the correct order. It really should be bronchopneumonia, MAC, and TB, because bronchopneumonia is far more common. So I would have given myself only a 70 for that particular for that order. Okay, so anyway, airways infection on CT. What are we looking for? Bronchiectasis. If you see anterior distribution of bronchiectasis or nodules, like tree in bud, centrilobular nodules, that is MAC. Just say MAC is the most likely diagnosis, especially if you see anterior distribution, meaning what? Lingula, right middle lobe, and anterior upper lobes. It doesn't have to be only the anterior distribution, but that's slightly predominant distribution. Also, you can see bronchial wall thickening and mucus plugging with airways infection. Centrilobular nodules are very common, especially tree in bud nodules, which is the branching pattern. And mosaic perfusion and air trapping, again, that comes up. That's also seen in airways infection. So this is a patient with centrilobular nodules, nothing really touching the periphery except maybe that little one right there. So centrilobular nodules, this person had active tuberculosis, airways TB. How about this one with tree in bud infection, tree in bud pattern? This is bronchopneumonia. So it's very important to be able to identify centrilobular versus random versus peri-lymphatic nodule distributions. And if you see tree in bud, that is infection, bronchopneumonia, MAC, TB. Okay, another patient with airways infection. Look at the central bronchiectasis as well as bronchial wall thickening, and then we see nodules out in the periphery, centrilobular nodules. This was MAC, okay, anterior distribution, but there are also some in the lower lobe back here. Bronchiectasis here as well. So nodules, centrilobular nodules, airways infection. Another patient with MAC, anterior distribution is characteristic. Look at that bronchiectasis and bronchial wall thickening, and then we see some conglomeration of nodules here. Okay. Bronchiolitis obliterans, just a few more minutes. This is obliterative granulation tissue in the lumen of the small airways, and this can lead to air trapping. It can be post-infectious or post-inhalational. Collagen vascular disease can cause bronchiolitis obliterans, graft versus host disease, and chronic lung transplant rejection. That is another cause of bronchiolitis obliterans. On CT, what are we looking for? Bronchiectasis, mosaic perfusion, and most sensitively, air trapping. You may see nothing else but air trapping. So if you see nothing else but air trapping, differential is what? Bronchiolitis obliterans. What else? I'm trying to think. Asthma and hypersensitivity pneumonitis. Good. Okay, so mosaic perfusion, in this case it was bronchiolitis obliterans, also has enlargement of the airways, bronchiectasis. Different patient. So inspiratory, expiratory, air trapping, nothing else was really seen except air trapping, asthma, bronchiolitis obliterans, hypersensitivity pneumonitis. Okay, and with that, a couple of words on hypersensitivity, also known as extrinsic allergic alveolitis. Now, I'll tell you a little story. Okay, bird fancier's lung or farmer's lung or other terms. It's caused by exposure to organic dust and essentially a reaction, an immune reaction to organic dust. Initially, patients develop fever, chills, cough, and dyspnea. That's the initial systemic, non-specific syndrome. They develop these findings, and if you do a CT scan, you may see the ground glass opacity all over the place, either diffuse, patchy, or centrilobular nodules. And later on, what happens if the agent that's causing the disease, for example, the birds, are not removed, then this becomes chronic, and it can develop into fibrosis and develop into honeycombing, which is end-stage lung disease. So the symptoms resolve if exposure stops. Okay, so ground glass opacity, one of the most important findings, especially in acute disease, and that can be patchy, diffuse, or centrilobular nodules. You can see mosaic perfusion and air trapping. Air trapping may be the only finding. You may not see ground glass opacity at all. Head cheese sign, which has already been described to you. And then in the chronic setting, fibrosis, if this has progressed to chronic disease. Now, centrilobular nodules of ground glass opacity, this is hypersensitivity pneumonitis, and other things can cause it too, but for your purposes, it's most likely hypersensitivity pneumonitis. See, they're nodules of ground glass opacity. And sometimes when I've given the board exam, I've given a hint, so someone doesn't know it at all, so I say, well, works in an aviary. And usually by that point, they will get it. Okay, now if someone asks, what's an aviary, then I usually just like to move on to the next case too. An aviary is a place where birds live, okay? To give them a chance to make it up on the next cases, okay. So anyway, air trapping, do you see air trapping here? Not really. On the expiratory views, yes, there's definitely air trapping, and in this case, it was hypersensitivity pneumonitis. And the head cheese sign, which is essentially ground glass opacity plus the lower attenuation of mosaic perfusion, also seen with hypersensitivity pneumonitis. So ground glass opacity, mosaic perfusion, air trapping, those are the most important things to look for in hypersensitivity pneumonitis.
We're going to talk a little bit about pulmonary nodules and masses. Let me first go through a couple of unknowns here for you. Take a look at this radiograph, characterize it, and tell me what you think the syndrome and its components are. Number two, characterize this and take your best stab at a diagnosis. Number three, it's a young patient, and there's a suggestive finding on this particular image. Number four, differential diagnosis. And last one, we'll talk a little bit about lung cancer staging at the end of this talk, so take your best shot at staging this left upper lobe carcinoma. If you don't know the exact stage, just tell yourself, is it surgical or non-surgical? That's really what matters the most. Okay, nodules and masses. Definition, this is actually the Fleischner Society definition, a little modification of definition of a pulmonary nodule. Any pulmonary lesion in a chest x-ray, seen in a chest x-ray, fairly circumscribed or sharply defined, fairly nearly circular with a size range, 2 to 30 millimeters. One thing that's not in the Fleischner Society definition, but I think is important to keep in mind because this is what we do on a day-to-day basis, is to qualify a nodule. Qualify regarding to its size. If it's bigger than 3 centimeters, as I'll discuss in a second, we call that a mass, and there's a reason for that. Its shape, is it round, is it oblong, is it tubular? Its density, does it have calcium, does it have fat in it? Its border characteristics, is it sharply circumscribed, is it poorly defined? Is it a single nodule, is it multiple? And then of course the patient demographics. A solitary nodule in a 20-year-old is a very different animal from a solitary nodule in a 70-year-old with emphysema. And a mass is just the same thing, only the nodule measures greater than 3 centimeters. You pretty much approach a mass the same way you do a nodule, but you have to keep in mind the reason why the word mass was kept as a separate definition just based on size is it sounds bad. And mass sounds bad because most things over 3 centimeters in the lung are usually going to turn out to be something bad like cancer. Not invariably. We'll see there's a differential. But it ups the ante a little bit when you see a large lesion that you got to be pretty sure that you got some benign criteria before you pass off on it. Diagnostic considerations for multiple or solitary pulmonary nodules or masses are enormous, as we all know. You can break them up according to a different schema. One thing I like to do is to think of neoplastic causes, and bronchogenic carcinoma, or BCCA here as I have it abbreviated, is overwhelmingly the largest malignant consideration that you're thinking about. Lung mets are actually number one, but we're talking solitary nodules. Usually primary bronchogenic carcinoma is the thing we're worried about. Pulmonary lymphomas do occur, and we'll talk about those. And there are certain primary neoplasms of the lung that are not bronchogenic in nature, and they're pretty rare, but we'll talk about those. Metastases, either as multiple nodules or solitary nodules. Surgical series metastases are somewhere between 5 to 10% of solitary nodules, so it does occur. Benign lesions, hamartoma is overwhelmingly leading the list, and there's a whole bunch of different OMA-type lesions that can occur in the lung that are usually surgical diagnoses because they're fairly nonspecific looking. Infections, big ones being fungus, parasites, and bacterial abscesses, and we'll talk about those. Congenital lesions, certain non-infectious inflammatory lesions, and I'm emphasizing Wegener's here. We'll talk a little bit about sarcoid as well. And then certain non-parenchymal lesions, so something else maybe from the pleural space or from the chest wall that simulates a pulmonary nodule on imaging. Let me just briefly review bronchogenic carcinoma. It's important to have a decent amount of knowledge about this particular entity because you're going to see it commonly. There are at least 4 separate types that we think of, adenocarcinoma being the most common. It's increasing in frequency, and it's the one we're seeing more and more in women these days. There's a little change in the demographics of this neoplasm. It's probably about half of all bronchogenic carcinomas diagnosed. It has the weakest association with smoking. Most of them are peripheral. The vast majority are peripheral, manifesting as solitary nodules or masses. They tend to occur a little bit more in the upper lobe, at least in large surgical series, but you really can't rely on that too much. They could occur anywhere. It's the lesion that tends to be associated with scars, and whether or not the scar actually plays some role in the pathogenesis is uncertain. But when you see a nodule developing in a region of scarring or fibrosis, you worry about adenocarcinomas. And pathologically, it's characterized by slow growth, but unfortunately, it tends to metastasize early. That's one of the reasons it's associated with poor survival. This particular case you're looking at here, nothing specific about adenocarcinoma. It's just a large pulmonary mass, and given its size, you'd be worried about a malignancy. But it could be one of the multi-differentiated neoplasms I'm going to discuss shortly. It could be a large cell carcinoma. It could be a pulmonary lymphoma. It could be a lot of different things. But anything this big is usually bad news. A subtype that you want to be aware of, Bronchioloalveolar Carcinoma. So a couple of reasons to be aware of it. Number one, certain varieties of BAC, as I'll abbreviate it, are associated with a little better prognosis than other adenocarcinomas. Number one. Number two, certain BACs will have characteristic radiographic presentations that are different than other varieties of adenocarcinoma, such as lobar consolidation, multiple poorly defined nodules, almost an airway type spread pattern. These are peculiar to BAC. Here's the most common manifestation of bronchioloalveolar carcinoma. More than half of them will present as solitary nodules or masses. Pretty good sized lesion here on the left side of the screen. You can actually see a little enhancing nodule in here. This patient on chest radiograph, you can actually see a little focus of what turned out to be calcification in this lesion. Calcium is usually more often associated with benign causes of nodules, but when you see this much non-calcified tissue, you certainly have to be worried. And I'll make that point again during this talk, during my interesting case talk, and tonight when we do the unknowns. Number two is squamous cell carcinoma. About 1/4 or so of bronchogenic carcinomas. It has a very strong association with smoking, and it's usually a central neoplasm. So adenos and large cells, peripheral and small cell and squamous cells tend to be more central. It's a fast grower, but it tends to be slightly more associated with later metastases, and its local fast growth with an endobronchial location and propensity for later metastasis have given this subtype of bronchogenic carcinoma a little better 5-year survival than the other three. Tends to be the lesion when you see an endobronchial lesion that's turns out to be a bronchogenic carcinoma, usually squamous cell. It's the one that can get cavitary, and it's the one that can show central necrosis, more common than the other varieties. Pretty obvious what we're dealing with here, a very large cavitary mass. And I'll also discuss this in the unknown case session tonight. When you see cavitation and you're looking at a lesion that's cavitary on a radiograph or a CT, we look at the inner character of the wall and the wall thickness, which you characterize at the thickest area, not the thinnest area, but the thickest area that doesn't have an air fluid level. And this feature allows us to diagnose this lesion as malignant. It's probably in excess of 2 centimeters thick here with a lobulated internal character that strongly suggests neoplasm over an inflammatory lesion. This is actually your first unknown. This is a squamous cell carcinoma. You can see it's hiding in the lung apex here. This is actually a Pancos tumor, and we'll talk about the components of the syndrome in a second, but I should mention when you see asymmetric opacity in the lung apices like this, we see that quite common, at least in San Francisco, and particularly San Francisco General. There's a lot of tuberculosis infection. The one thing, there are a couple things should tip you off here. It's asymmetric to the opposite side, and there's no features of volume loss or scarring surrounding this lesion. TB and other inflammatory diseases will tend to cause a more scallop look. They'll pull the hilum up, they'll pull the trachea towards the side of the lesion, indicating there's some volume loss. You can see there's really no distortion going on around here. So this asymmetric apical pleural thickening type appearance isn't necessarily post-inflammatory. It's one of the clues to the diagnosis that something bad is happening in this apex up here. On the MRI scan, you can see that this lesion is actually invading through the top of the chest wall, which is right about here, up into the tissues superior to the lung apex, causing Horner syndrome. Part of that syndrome is ipsilateral anhidrosis and meiosis due to the impact on the parasympathetic ganglia and sympathetic ganglia. And often you'll have some upper extremity weakness as well when the brachial plexus is involved, and this patient definitely had that. We'll see that this makes you T4. If this is a lung carcinoma that you come across and staging it, once you got brachial plexus involvement, it's a T4 lesion. Small cell carcinoma is number 3 on our list. Around a fifth or so of bronchogenic carcinomas. Tends to be central in location, and it usually manifests on radiography or CT as a perihilar mass. It's very hard to tell what the primary lesion is and what the lymphadenopathy is, where one starts and the other leaves off. It's usually just a conglomeration of lymph nodes in the hilum and mediastinum. This is a lesion that tends to be associated with paraneoplastic syndromes like syndrome of inappropriate ADH secretion. It may also cause SVC syndrome. It's the most common bronchogenic neoplasm to give you an SVC syndrome. And it's characterized by the worst of both worlds, pathologically speaking. It tends to grow very fast, and it tends to spread rather early. So most of the cases when you see these diagnosed, at the time of diagnosis, 3/4 of them will be what's called extensive disease, meaning it's outside the thorax as opposed to confined. Remember that small cell carcinoma is not staged the same way that other bronchogenic neoplasms are. At the end of this talk, I'll come back to that point. Large cell carcinoma, nothing really specific about this. It's a fairly uncommon neoplasm as far as bronchogenics go, well less than 5%. It tends to present as a rather large, nonspecific peripheral mass, and the reason why it looks aggressive is because it's usually quite large at presentation, nonspecific looking. It tends to grow very fast and tends to spread very early, which makes it overall very poor survival. Nothing very specific about this, and it's going to look a lot like some of the other neoplasms I'm going to talk about in just a second. Pulmonary lymphoma, primary pulmonary lymphoma is a fairly unusual diagnosis, but it does occur. Remember, there are lymphoid cells sitting in the pulmonary interstitium, so-called mucosa-associated lymphoid tissue, MALT, or BALT, bronchus-associated lymphoid tissue. Neoplasms in the lung that are lymphoma tend to be of B-cell origin. They can present in one of probably 3 separate ways is the way you could break it up. Multiple nodules, and they're usually bigger than a centimeter. Once in a while, you'll get almost a sarcoid kind of look, a perilymphatic distribution. That's pretty rare, but it's been described with lymphoma. Usually the nodules are bigger. Multifocal consolidation-like appearance, much like this case here on your left. It superficially looks like consolidation. Until you look closer, you see there's no bronchogram in there. And that's not uncommon with lymphoma, that there's no bronchogram within the lesion. I wouldn't say it's diagnostically specific, but when you see mass-like areas of consolidation, lymphoma is something you want to think about. Or it can present as a solitary nodular mass. Those are probably the 3 biggest presentations. We tend to see these lymphomas more commonly in severely immunocompromised patients, particularly patients with AIDS with low CD4 count. That's what you have here on your left. This is a patient with AIDS and low CD4 count, but not invariably. This patient here did not have evidence of AIDS, was otherwise immunocompetent patient, just happened to develop a lymphoma in the lung. Whether you have AIDS or not with pulmonary lymphoma, it usually presents as an isolated lesion involving the lung itself as an organ and not not within the lymph nodes, either mediastinum or hilum. It's in distinction to lymphoma. Usually when you're thinking about the mediastinum, you see mediastinal and hyalulymphadenopathy. When it's occurring primarily in the lung, it tends not to be accompanied by lymph nodes elsewhere. Tend not to see effusion very much either. It does happen, but it's uncommon. Adenosquamous carcinoma is one variety of what's often referred to as multi-differentiated pulmonary neoplasms. These are primary neoplasms of lung that have mixed cellular elements in them, or they could be sarcomas or combinations of carcinoma and sarcoma. In general, they're pretty nonspecific looking. They tend to be often peripheral large masses, such as what you see here on your right. They tend to grow very rapidly and spread early. So they behave a lot like aggressive adenocarcinomas or large cell carcinomas. Tend to be associated with poor survival. Another variety is a carcinosarcoma. I could easily label this picture as carcinosarcoma. They don't look any different. There's nothing you can tell about differentiating one or another histopathologically. All you can look at is when you see a large mass, you assume it's something bad, and it could be one of these varieties of tumors. Large mass, nonspecific appearance. Don't forget about metastases. As I mentioned, obviously they're a big cause of multiple nodules or masses in the lung, but they can present as solitary nodules as well. Here's a lesion here on your right, large mass in the medial aspect of the right lung apex. Looks very much like that lymphoma that I just showed you on the last slide. No definite way to tell the difference, but the patient's clinical presentation and usually some kind of histologic diagnosis via biopsy or resection is going to be required to say for sure what you're dealing with. I showed this particular case as osteosarcoma just because I want to reinforce the point that when you see calcium within a lesion, it's usually going to indicate the lesion's benign. It may be absolutely benign if you have a certain pattern, but all bets really kind of fall off when you're dealing with calcifying or osseous neoplasms like osteosarcoma and chondrosarcoma. So even though this lesion is fairly heavily calcified in this patient with osteosarcoma, you got to be worried about carcinoma or malignant spread, in this case sarcoma. How about benign pulmonary neoplasms? The biggest one you want to think about is hamartoma, proliferative lesion in lung. There are a few others. These are usually proven on pathology. There's nothing specific on imaging. Entity called a sclerosing hemangioma, and once in a great while you may actually see amyloid, little focal amyloid collections in the lung, so-called amyloidomas. This is actually your number 2 unknown case. This is a giant hamartoma. You can see nice on this scout view for the CT scan. Fairly circumscribed lesion, and on the CT itself, multiple little areas of calcification. Again, reinforcing the fact that when you have a lot of calcium in a lesion, it's usually but not invariably benign. The pattern is going to be most important. In this particular case, the pattern is roughly suggestive of something chondroid, but this is a sort of lesion that will be followed closely after a biopsy to make sure it's not growing, or it'll be PET scan. There'll be some other element you'll have to add into your workup to be absolutely certain a lesion this size is something benign. It doesn't need to go to surgery. Quite often a large hamartoma like this is going to go to surgery anyway because the local mass effects necessitate removal. We'll talk a little bit more about hamartoma specifically in the interesting case session as well. Hamartomas in general are fairly circumscribed or well-defined lesions. They can be smooth contours or show lobulated contours, and you may see calcium on a chest radiograph, and if you do, it's often chondroid or popcorn in nature. On CT, there's a classic study from Hopkins in the mid-80s or so. 38% showed fat in the lesion on CT scanning, 4% showed calcification, which may have a specific pattern, and 21% showed both. So in over half the cases, you could be diagnostic of a hamartoma with CT scan if you're paying attention to some of the particular elements that hamartoma may show. You're still going to biopsy some of these are going to go to PET scan, and some are going to get resected because they're not going to have histologically specific findings on the CT scan. How about infections of pulmonary masses? Major considerations: fungus, lung abscess, and parasites. Now you can get multiple small nodules with disseminated infections, as I reviewed in my previous talk, so I'm focusing a little bit more on larger lesions. You can get smaller lesions with septic emboli that cavitate. It's a pretty diffuse talk to get your hands around, so I wanted to focus on larger lesions with this element of the talk. What do you have to think about? Nonspecific appearances in general for these lesions, but the clinical presentation is often but not invariably suggestive. So you may have somebody that's grossly febrile, shaking chills. That makes it pretty easy. Other things you have to maybe look for if you're thinking about abscess: maybe the patient's an aspirator. They have neurologic dysfunction or altered mental status or something like that. It's not uncommon the clinician may not actually put that together, and you have to be the one to suggest it. So it's important to raise those possibilities. You also may see other findings on the scan that would suggest something inflammatory. So a lot of surrounding consolidation, or maybe endobronchial spread with a tree and bud pattern surrounding the abscess. That would be a good indicator you're dealing with an infection and not a malignancy. So a couple of cases of fungus causing large masses in the lung. Is there anything specific about this? Absolutely not. A lot of what you're seeing here really depends on where you practice. San Francisco is kind of in the tail end of the coccidioidomycosis belt, so you'll see cocci now and again around here, and you have to think about that, and you have to modify your practice according to where you work. If you're in the south somewhere on the East Coast, you're not going to see much cocci down there, so you may manage nodules differently. I work in Arizona now, and I see coccidioidomycosis almost on a daily basis. So a lot of nodules that look like this, or things that look like cancer, are going to undergo biopsy because you have to differentiate them before they go to the OR. So you got to modify your practice based on where the local demographics and epidemiology of a disease. In this case, this patient on your left here, the cocci case, was biopsied. They found characteristic features, treat with antifungal, and the lesion goes away. Cryptococcus, more commonly you're going to see in immunocompromised patients, but once in a great while, like this patient, you may see it in an immunocompetent patient. They may be associated with people who are hiking through caves and whatnot, and sometimes it's just somebody who comes off the street and for whatever reason they got crypto. So when you think of fungus, you got to think about cocci and crypto and the other endemic fungi as potential causes for lung masses. This is a pulmonary abscess, 2 cases here. The case on your left is actually frank pulmonary gangrene, which may happen once in a while with a really aggressive abscess. This patient actually infarcted their large abscess, and this is actually a chunk of lung that should normally be tacked up right around here or so. And it actually just fell away as the lung, the infection more or less infarcted all the blood vessels feeding this abscess cavity, and the lung just fell away. This is what's been referred to occasionally in the literature as the iceberg sign, this hunk of lung kind of floating on the rest of this stuff in the abscess cavity. This is also another lung abscess here, and this is a patient who didn't classically present with shaking chills and whatnot. This is a patient who did have features that would suggest clinically that they were aspirators, and often these patients may present with low-grade shortness of breath or a cough and not too much of a fever with a sort of prolonged history that smells more like a neoplasm. So you have to think about that when you see a large lesion like this showing areas of low attenuation, suggesting necrosis. How about congenital lesions that may cause multiple nodules or in particular masses? Major considerations: bronchiolitresia, congenital lobar emphysema. Before it fills with air, it may have fluid in it, so you may see a mass in a neonate. Congenital cystic adenomatoid malformation, that often goes by another name now, congenital pulmonary airway malformation, CPAM. That's what the pathologist called it. It'll eventually permeate our literature as well. Sequestration and bronchogenic cysts. Sequestration is probably one of the bigger ones you want to think about. So I'm going to focus on that a little bit. Really come in two varieties, extralobar and intralobar. And it always comes up, how do you differentiate these two? Probably there's a few rules that I think I'll show you right now that'll give you the best chances. Nothing's 100%, but it's a pretty good indicator, 90+%, as to what type of sequestration you're looking at. Young kids, think extralobar sequestration. Intralobars usually present in adults or young adults with recurrent infections. So if you're seeing it in a child, chances are it's an extralobar sequestration. If you're seeing it in adults, probably intralobar. Both have systemic arterial supply, so that doesn't help you, but it does help you diagnose sequestration as opposed to another cause of a congenital mass, such as a CCAM, which is not going to necessarily have an aberrant vascular supply, nor bronchial atresia or congenital lobar emphysema. Systemic venous drainage is characteristic for extralobar sequestration. Pulmonary venous drainage is more characteristic for intralobar. This is by no means absolute, and of all the rules that I'm giving you, the venous drainage is probably the least reliable, so don't fixate on that too much. In general, extralobars tend not to contain air, so they're fairly mass-like. This case on your left here looks like a big mass in the patient's lung. Intralobars often do contain air, particularly if you image them during the quiet phase when the patient's not infected. This patient was presenting with infection, and then they got basically an abscess within the intralobar sequestration. You can see there's a little spot of air here. This is actually your unknown number 3, and what I wanted you to notice was this aberrant vessel emanating from the descending thoracic aorta, which is pretty characteristic for both lesions supplying the mass. That's what you're looking for when you want to diagnose sequestration and distinguish it from other causes of neonatal lung masses. Extralobars tend not to be infected. Intralobars tend to present with infection at some point. So recurrent pneumonias in a young adult, that should send up a red flag. You may be dealing with a sequestration. Inflammatory lesions, major considerations. Wegener's, I wanted to focus on. Amyloid, I kind of mentioned. You can see multiple nodules in patients with rheumatoid, and cases of progressive massive fibrosis, which would be complicated silicosis, or maybe a patient with sarcoid. Anything ending with the word oid, Wegenoid, you have to BS it a little bit, Wegenoid, rheumatoid, and sarcoid, they can all give you lung nodules and lung masses. And a rare lesion, inflammatory myofibroblastic tumor, formerly known as plasma cell granuloma. I'll show you that one during the interest case discussion. Pretty typical case of Wegener's. This disease is fairly rare, but can be characteristic on imaging, so I wanted to go through it specifically. Multiple nodules, usually soft tissue attenuation. They tend not to calcify too much. The lung is involved in at least 85% of cases of Wegener's, and it causes pathologically a capillaritis, which causes the lung to bleed, so you may see these patients presenting with hemoptysis. Most common presentation on imaging, nodules with or without cavitation. At some point, usually you see cavitation. Secondary consideration, diffuse lung opacity, often ground glass opacity due to capillaritis and associated pulmonary hemorrhage. You may see an airway stenosis in patient with Wegener's, often without other lung findings. And this is an important clinical vignette here, is the C-ANCA anti-neutrophilic cytoplasmic antibody is positive in more than 90% of cases. That's how you approach these cases. You see multiple nodules, you think this could be Wegener's, tell the clinician to get a C-ANCA antibody. If it's positive, you probably just nailed the diagnosis. If it's negative, you move on to one of the other oids and try and squeeze out some clinical radiographic features to order your differential. So it's very important to be aware of certain features, clinically and laboratory data-wise, that will allow you to make the diagnosis. How about non-parenchymal lesions? Your major considerations are lesions from the pleura. So you could see loculated fluid that simulates a lung mass, solitary fibrous tumor of the pleura, mesothelioma, and metastases to the pleura. The one I want to focus on is solitary fibrous tumor of the pleura because it can look like a real lung mass. You may see lesions from the chest wall that can simulate a lung mass, usually metastases, or even a diaphragmatic hernia can look like a lung mass as it's squirting up into the thorax. This is a solitary fibrous tumor of the pleura, is also one of your unknowns, number 4, I believe. A large soft tissue attenuation lesion in the inferior aspect of the right chest. Lots of contact with the pleural margin here, but there's really no definitive way to say this thing is in lung or coming from the pleura. And when you get a lesion that's probably 20 centimeters in diameter, that's always going to be the case. Very difficult to know exactly where it came from. In this case, you have to remember that solitary fibrous tumor of the pleura may present very large, circumscribed lesion up to 40 centimeters, one of the largest ones reported, occupying the whole thorax. That's how you suggest this diagnosis, particularly when the patient's not dying of metastatic disease or something else and they have a giant mass in their chest. You may want to think about unusual lesions. They may calcify, usually in the minority of cases. Effusion, even though it's a lesion from the pleural space, effusion is not that common. They usually enhance in some areas rather vigorously, and characteristically they may be associated with hypertrophic pulmonary osteoarthropathy. These lesions are more associated with HPO than bronchogenic neoplasms are. Overall, bronchogenic neoplasms are much more common than this lesion though. Hypoglycemia is a characteristic thing that comes up on written boards all the time and you almost never see in practice, but these lesions may secrete insulin-like growth factors and cause hypoglycemia. And if you happen to catch one on MR, they may have fibrotic elements, so they may show low signal. They can be malignant too. Most of the time they're thought to be benign. When you have a lesion this big and you biopsy it and it looks benign in this area, it doesn't mean it's not malignant in that area. And if you follow these over time, a lot of them may actually transition into malignancy. So it's current thinking is when you come across these lesions, they're probably more likely going to get resected on the assumption that it's benign now, but we don't know where it's going to be 5 years from now. So let me finish up with a little lung cancer staging, and I'll try and make it simple for you. Just run down some of the features that tell you what stage is what, then I'll tell you exactly what I think you should do in terms of dealing with lung cancer staging. So a T1 lung carcinoma can be up to 3 centimeters in size. It should be completely surrounded by lung. And there should be no invasion of a main bronchus. If you have any of these latter two features, it's not T1, it's going to be something else. This is a pretty classic T1 lung carcinoma. As we'll see, this is associated with the best possible survival for bronchogenic neoplasia. It's a solitary lesion, maybe about 2 centimeters, spiculated margin. It's well away from the chest wall and well away from main bronchi, so it's a T1 lesion. As long as there's no lymph nodes or metastatic disease, this is the best possible survival situation for bronchogenic carcinoma. T2 has to be, by definition, more than 2 centimeters away from the carina. It can be, one way to get into the T2 category is to have a lesion that measures 3 centimeters or more, or greater than 3 centimeters. This lesion is about 3.5 or 4 centimeters with a little cavitation in it, so just based on size alone, it was T2 lung carcinoma. Visceral pleural invasion will get you into the T2 category. Here's about a 3 centimeter mass or so, touching the right major fissure here with lots of strands or pleural tags touching the pleural surface. This is not a guarantee that this lesion is invading the pleura, but it is a suggestion. And usually these are things that are going to get proven at surgery. There'll be post-surgical staging. Pathologists will say, yes, the visceral pleura is involved, and the surgeon will see the adhesions, and then the patient will have their stage adjusted accordingly after the operation. If you have a lesion that causes collapse or consolidation of less than the entire lung, that's T2. So the classic case of left upper lobe collapse that you see from an endobronchial neoplasm, if nothing else is going on, that's a T2 lesion. And this is just such a case here. A T3 lung carcinoma, invasion of any of these structures, parietal pleura, diaphragm, chest wall. You see a solitary nodule, always look at those ribs. You can actually see the cortical margin pretty well here, and then it's eaten away here. On the CT scan, the lesion is clearly invading into the chest wall. That automatically gets you into the T3 category. Important observation to make. It changes staging and it changes the way the surgeon's going to approach the case. They're going to have to reconstruct the chest wall to get this thing out. On MR, you can sometimes see signal intensity extending out into the chest wall and may have some value in deciding whether or not chest wall invasion is present. Parietal pericardium being invaded gets you to T3. Or if the lesion is less than 2 centimeters from the carina, or if you see collapse or consolidation of the whole lung. The whole lung goes down due to central neoplasm. It's close to the carina, not involving the carina. It's a T3 lesion. A T4, any size, small or large, with invasion of the following structures: the heart, large mass here, eating into the mediastinum, invading into the region of the left atrium. This much contact and lobulation and impression certainly suggest invasion of the heart. Invading the vertebral body, like you see here, this is a patient presented with Horner syndrome. Invading the great vessels, clearly the pulmonary artery here is surrounded and invaded when it's narrowed to that extent. Invading the esophagus, this lesion is very immediately located in the left upper lobe. You can suggest invasion here, but it should be confirmed, because invasion making this lesion T4 is probably going to make it non-surgical, so that should be confirmed by a better study, in this case endoscopic ultrasound, where they could see the invasion. You want to suggest it here so you get the patient to the right test to make that diagnosis. Invading the trachea and carina, that gets you to T4. Invading the brachial plexus, here's another lung apex neoplasm going into the chest wall. Presence of a malignant effusion or satellite nodules. As we'll mention shortly or a little later on, satellite nodules, when you're talking about diagnosis of a solitary nodule, usually suggest a benign lesion. Once you've established malignancy, nodules that are in the same primary lobe as the tumor are considered satellite nodules, and their presence is usually associated with a worse survival. That's what we mean by satellite nodule. That gets you to T4 if that's proven. It's a little controversial, but that's the way the staging system is at present. Lymph nodes, N0 is easy to remember, no lymph nodes. N1, ipsilateral hilum, or out in the lung parenchyma. All these are actually outside the pleura in the lung, so they're not inside the mediastinal pleura. N2 means you got past that pleural envelope and you're in the mediastinum. When you're dealing with lymph nodes, you give the benefit of doubt. If this thing's right in the midline, you assume it's ipsilateral. That's how the staging system works. Or contralateral lymph nodes, and this is your last unknown. Left upper lobe neoplasm, ipsilateral mediastinal lymphadenopathy, N2, contralateral mediastinal adenopathy, N3. This will be a stage 3B neoplasm and generally considered non-surgical. Metastasis, very easy to remember, present or absent. Here's a left upper lobe lesion, bilateral adrenal metastases, so M1, automatically stage 4 disease. So putting it all together, stage 1 has a 1A and a 1B. It's just T1 versus T2. That's all it is, N0, M0. Note how the survivorship drops slightly. That's why we do this staging system, is to determine patients' prognosis and to group patients with the same prognosis similarly so they can undergo treatment clinical trials. Stage 2, just add in the lymph nodes. T1, N1, T2, N1. Again, see the survivorship drops. Stage 3 has a 3A and 3B. T3, N1, and T1 through 3, N2. So as soon as you go N2, you're automatically getting into that stage 3 category. And then non-surgical disease is stage 3, 3B, which could be any T4 lesion is going to get you to 3B, and any N3 lesion, so contralateral mediastinal lymph nodes. Of course, stage 4 is metastatic disease. So this is usually where surgical therapy is decided yes or no. Anything above this level, stage 1, 2, or 3, could be surgical, or at least stage 3A. Note that that's controversial. In practice, a lot of patients with 3A disease will not go to surgery because there's been no large-scale trials that show there's a benefit. But technically speaking, this is the way the last staging system reads. 3A disease is potentially surgical. Everything beyond that is non-surgical. And that's what your job is as a radiologist, is to discover surgical versus non-surgical disease.
I'm going to be discussing mediastinal and pleural disease. And let's start with the unknown cases. What could this be? Luckily, this isn't an actual test, but just think to yourself. So what could this be? Next case, case 3. That's pretty interesting, isn't it? Okay, case 4. Try to come up with 1 or 2 possibilities. And case 5. Okay. Okay, so let's start out with the mediastinum. I'm going to discuss a few diseases in the mediastinum. Let's start out with thymic masses. Thymic masses are in the anterior mediastinum, as you know. They include thymoma, invasive thymoma, thymolipoma, which has fat, and thymic cyst. Okay, so thymomas are most common in patients over the age of 40 years. If patients in their 20s or 30s, you probably shouldn't include thymoma in the differential diagnosis. You should not, unless there's a reason to. For example, they have myasthenia gravis. If the patient has myasthenia gravis, then thymoma is definitely a consideration for an anterior mediastinal mass. 35% of patients with thymomas do have myasthenia gravis. Thymomas are usually encapsulated, but they can be lobulated. They don't have to be round or oval. They can be lobulated. They can be homogeneous most commonly, but occasionally they are heterogeneous, and this can be a little bit confusing when you see them heterogeneously, when you see them presenting heterogeneously, because they can have hemorrhage, cysts, cystic elements, or calcification. And invasive thymoma accounts for 30% of all thymomas, and this can invade the mediastinum, lung, or pleura. So it tends to be irregularly and poorly marginated, invasive thymoma. Okay, so how about this particular case? It's an anterior mediastinal mass. It's homogeneous but lobulated. What could this be? Differential diagnosis is what? Not too difficult a case, at least in my opinion. Probably because I already know the case. Okay, so thymoma, lymphoma, those are probably the two most likely things. This turns out to be a thymoma. The older patients, I would say, include thymoma in the differential. If this were a 20-year-old, I would be worried more about lymphoma than thymoma. How about this particular case? Look at this mass. It has calcification. It's heterogeneous. It has a cystic element. This is actually a thymoma as well. It turns out to have cystic elements. Now, it's not a thymic cyst in that thymic cyst is typically mainly just a big cyst. This is a thymoma that has cystic elements and calcification. It's irregularly marginated and also ill-defined. It may well have been an invasive thymoma, but we didn't see it invading anywhere, so we just call this a thymoma. How about this? This is a patient with a known thymoma and masses in the pleura. So invasive thymomas can invade the mediastinum, or the lung, or the pleura. And in the pleura, these are called drop metastases. So pleural masses, differential diagnosis includes thymoma, invasive thymoma with drop metastases. And I will be discussing pleural masses later on in this talk. Let's move on and talk about thymolipomas. These are rare and benign. They're encapsulated. They are not invasive. They can cause compression. 50% of the patients have compression of mediastinal structures, such as the trachea or vessels. They're composed of thymic tissue and fat and usually heterogeneous. And these are actually quite unusual, but people love to talk about them and show them because it provides us a little bit of intellectual stimulation. Not too much, but a little bit. So what do we see here? There's fat, soft tissue elements. There are septations. This turns out to be a thymolipoma. Okay, germ cell tumor. These are usually where? In the anterior mediastinum, if they are in the mediastinum. They're usually anteriorly located. 80% of the patients are less than 40 years of age. So germ cell tumor, under 40, thymomas, over 40. Most of them are benign, and these are mature teratomas most commonly. Malignant ones are less common, but they include seminoma, embryonal cell carcinoma, choriocarcinoma, and mixed germ cell tumor. Okay, so mature teratoma, most common germ cell tumor in the mediastinum, 75% of germ cell tumors. So these are benign, thankfully. They're composed of 2 or all 3 embryonic layers. Patients may be asymptomatic or symptomatic, and if they're symptomatic, they get symptoms of compression of adjacent structures, such as the airway or vessels, or they can have pain secondary to rupture. These masses tend to be encapsulated and multiloculated. They can be composed of multiple elements: soft tissue, fluid, fat, calcification, or teeth, even teeth. If you see calcification, fat in the mass, that's classically a germ cell tumor, but it can be other things. If you see fat, you're most likely going to be thinking of a germ cell tumor in a younger patient. Okay, it's unlikely to be a thymolipoma, germ cell tumor. However, interestingly, 15% of the patients have no fat or calcification. They only have fluid and soft tissue. But I would assume if you're going to be shown a case, it's going to have fat or calcification. Okay, so let's look at this particular case. There's a mass here. It actually turns out to be anteriorly located. And look at it on the CT. It's heterogeneous. There's fat, contains fat, and it contains calcification. This turns out to be a mature teratoma. Okay, so anterior mediastinal mass on the plain film differential diagnosis, germ cell tumor, thymoma, lymphoma. And in older patients, thymoma is more likely, under 40, teratoma or germ cell tumor more likely. Okay, malignant germ cell tumors. These are pretty unusual. Seminomas are one of the more common ones. They occur in young men. They're unencapsulated but well circumscribed. So they're not irregular or poorly marginated. They're well circumscribed, but there's no capsule. They're usually homogeneous. They're sometimes lobulated. Non-semitomatous germ cell tumors, on the other hand, tend to be large, heterogeneous, and invasive, so they really look malignant in that they're invasive with irregular margins, and they can also contain necrosis or hemorrhage. Okay, this is not a very good image, is it? Well, I'm not talking about the quality, but not a very good thing for this patient to have. This turns out to be a gigantic mass in a 30-year-old. And if you look on the CT, look at this huge heterogeneous mass. It actually contains calcification. This is a non-semitomatous germ cell tumor. It's malignant and huge, invasive, and irregularly marginated. It compresses the bronchus. Okay, let's move on. Goiter. This can be in the anterior mediastinum. Classically, people talk about anterior mediastinal masses that include goiter in that differential, but middle mediastinum is an important location for goiter. 20% of patients with goiter, it's been reported that 20% of these patients do have mediastinal extension. And goiters tend to be well marginated and lobulated, but they're frequently heterogeneous. In other words, they can contain calcium, cysts. They can also have sustained contrast enhancement in the thyroid tissue. And the most important thing when you're diagnosing a goiter, make sure it's contiguous with the cervical thyroid. It should be contiguous with the rest of the thyroid. Otherwise, there's no reason to mention it. It would just be very unusual to have an ectopic thyroid rest. Okay, let's look at this case. It looks abnormal here in the superior mediastinum. There's slight rightward deviation of the trachea. That can't be accounted for. We can't account for this simply by talking about the aortic knob. And then over here, what do we see? We see the anterior bowing of the trachea due to a middle mediastinal mass. What could this be? It could be lymph nodes, lymphadenopathy, such as from what? Metastases, lymphoma, sarcoid. The other thing to consider, mediastinal cysts, such as a bronchogenic cyst, or as in this case, this happens to be what? There's the thyroid gland here and here. This is contiguous with the thyroid. It's heterogeneous. Coming down inferiorly, we see how heterogeneous it is, and it's posterior to the trachea, goiter in the middle mediastinum. Let's move on. Lymphadenopathy. I never consider it adequate simply to say this person has lymphadenopathy. That's not a diagnosis. It's simply a finding, and a medical student could tell me that. So you have to make a diagnosis, lymphadenopathy. So what causes lymphadenopathy in the mediastinum? Well, just as in other places in the body, metastasis is an important consideration. Lymphoma, tuberculosis, other infections such as atypical mycobacterium, MAC, sarcoid, and AIDS-related lymphadenopathy. These are some of the more important diagnoses in a patient who could have lymphadenopathy. And metastasis from what? Well, carcinomas, squamous cell carcinoma, adenocarcinomas, breast cancer, lung cancer, etc. Okay. So one thing that people like to talk about is low-density lymph nodes versus high-density. And these aren't that common. Usually most lymph nodes are homogeneous and they have soft tissue density and they enhance. But sometimes if you see a low density lymph node, you have to be thinking about certain things. And what are those? TB, MAC, and metastases, especially from what? Squamous cell carcinoma can give you necrotic nodes, and certain types of adenocarcinoma, or certain patients with adenocarcinoma can have necrosis. So that gives you low-density nodes, the necrosis. TB, MAC, and metastases, especially from squamous cell, or sometimes from adenocarcinoma, lung cancer, breast cancer, renal cell carcinoma. How about high-density nodes, meaning denser than the surrounding soft tissue? There are two things to think about here, both of which are not very common: Castleman disease and Kaposi sarcoma. If there's an AIDS patient with high-density nodes, think about Kaposi sarcoma. So what do we see here? There's lymphadenopathy in the anterior, or there's an anterior mediastinal mass, which, again, differential diagnosis, lymphadenopathy due to multiple causes. What? Metastases, lymphoma, sarcoid, those are some possibilities. Thymoma, germ cell tumor. Okay, we see a homogeneous anterior mediastinal mass. This turns out to be a lymphoma, This was actually Hodgkin's lymphoma in the anterior mediastinum. But I do want to, again, point out, you can't really differentiate this from thymoma based on the image. How about this? Anything unusual here? Are these low-density nodes? Okay, so we have low-density nodes here. Differential diagnosis is what? TB, MAC, and metastases, such as from what? Squamous cell carcinoma, head and neck cancer, for example. Certain types of adenocarcinoma, I've seen lung cancer do this, breast cancer, and sometimes renal cell cancer. Not too common, but it occurs. If you see this, give the differential. How about this particular case? High-density nodes. Okay, look how old the study is, because this is the only case I have from when I was a resident, and believe it or not, that was a long time ago. Okay, so we see high-density nodes in the mediastinum, and this is Castleman disease. What is Castleman disease? Oh, actually, I guess I took out the slide for time savings, but essentially it's a vascular disease of the nodes, and certain subtypes of Castleman disease, because they are so vascular, they enhance and they become high density. Okay, so that's it. It's not very common. Next, mediastinitis. So infection is the most common cause of mediastinitis, but you should also know about fibrosing mediastinitis. And what is this? Essentially, patients get fibrosis and collagen, fibrous tissue and collagen. Most commonly, this is due to histoplasmosis. And in fibrosing mediastinitis, there's encasement and obliteration of the vessels, airways, and esophagus. So as it becomes more and more severe, it's first encases and then starts to obliterate, meaning that it starts to surround and compress the mediastinal structures. It's really highly infiltrative. And it can calcify. It frequently does calcify. And it's sometimes hard to differentiate from tumor because it does start becoming invasive. So this is a patient with fibrosing mediastinitis. You can see the abnormality here. It's very dense in the mediastinum. This is all calcification in the mediastinum. And look at the CT scan. Calcification that's infiltrating around. This is all fibrosing mediastinitis. And you can see here, that's the superior vena cava right there. Is that becoming encased and obliterated? I would say yes. This patient also actually had superior vena cava syndrome due to that encasement of the SVC. So this is fibrosing mediastinitis. Doesn't have to calcify this densely, but it typically calcifies and it becomes very invasive and infiltrative. So let's now move on. Let's talk about neurogenic tumors. So these are where? In the posterior mediastinum. What are some of the more common neurogenic tumors? Nerve sheath tumors, such as schwannoma, neurofibroma. And malignant nerve sheath tumors are actually pretty unusual, but schwannoma and neurofibroma are the ones to think about. And then the autonomic ganglion tumors can also be in the posterior mediastinum, and these include ganglioneuroma, neuroblastoma, for example, paraganglioma. So when we're looking at them, what are we looking for? Something in the posterior mediastinum that's large and heterogeneous. They can calcify occasionally. If they're well circumscribed, it suggests that they're benign. Most of these are benign. Malignant transformation or malignant tumors are rare in this particular category. They may have the dumbbell shape, meaning that part of it protrudes into the spinal canal. And you can also see vertebral anomalies associated with the tumor. And rib erosions also occur on occasion. So let's look at this particular case. This is a patient with, look at that neuroforamen, it's widened, and this is a neurofibroma, this particular one. It's posterior mediastinal. And there are also neurofibromas up here in this particular individual. That's pretty unusual, but that's a more characteristic one with widening of the neuroforamen. How about this particular case? There's a rib erosion right there. And right there, this is another patient with neurofibromatosis and neurofibromas there and there. So rib erosions, vertebral anomalies, widening of the foramen, that's the characteristic. And also the dumbbell shape. Okay, now extramedullary hematopoiesis, this is another posterior mediastinal mass. What is this exactly? Essentially, it's areas of soft tissue that produce blood cells. And when does this occur? Well, it occurs in the presence of severe anemia, such as hemolytic anemia or myelofibrosis. So anything that's either causing destruction of the blood or destruction of the bone marrow can result in extramedullary hematopoiesis. Characteristically, these are paraspinal and bilateral. So in other words, they're in the posterior mediastinum. They're at the levels T7 to T12 most commonly. And you can also see, besides the masses in the bone, you can see coarse trabeculation and rib expansion. So this is an example, very hard to see on the plain film. It's right here. But I wouldn't expect you to get that, especially since I didn't get it. Okay, so what do we see on the CT scan? We see paraspinal masses, and they're bilateral. So differential diagnosis, neurogenic tumor for posterior mediastinal mass, such as ganglioneuroma or neurofibroma. But look at the expansion of the ribs. Look how expanded these are. So if you see that, you can throw in extramedullary hematopoiesis because that is in the differential diagnosis for posterior mediastinal mass. Okay. Probably the last thing I'm going to talk about in the mediastinum, esophageal dilation. This can be due to what? Usually it's distal narrowing due to achalasia, stricture such as in scleroderma, or an obstructing tumor, such as what? Esophageal carcinoma or gastric carcinoma. So you can see a right-sided mediastinal mass that tends to be heterogeneous and coarse. Why? Because the esophagus is obstructed and you see ingested material within that esophagus. It's dilated. You can see an air fluid level. So azigoesophageal recess is a good place to look for that. An air fluid or fat fluid level can occur. How about this particular case? Look at that right there. What is this? That is an air fluid level. I hope you can see it, but there is an air fluid level up there. Okay, and look at this. Everyone can see this, right? There's gross abnormality of the mediastinum here and here as well. So this is marked enlargement of the esophagus with an air fluid level. That is achalasia. And this is how it looks on the CT. This is, there's the esophageal dilation. There is a fat fluid level. That is fat and that is fluid, ingested material, achalasia. But other causes of esophageal dilation, distal stricture, tumor. Don't forget this. This is not a mediastinal cyst. Okay, remember this in your differential if you see a fluid-filled structure in the esophagus. Okay, so let's talk about pleural disease. Pneumothorax is quite easy for most of you, but I'm going to show you a couple of examples of things that you could be fooled about or forget about on the boards because you're a little bit nervous and you're not thinking about things that you normally would be thinking about. Okay, so deep sulcus sign, do not forget that. Any ICU film, look at that, look for that, because if you miss it, you did not pass the case. Okay, tension pneumothorax, this is another type of pneumo that you might want to think about. This is a clinical diagnosis that results in circulatory compromise, but on imaging, what are we looking for? Contralateral mediastinal shift, mediastinal deviation to the other side, or depression of the diaphragm on that side. Diagnosis? A deep sulcus sign, this is a pneumothorax. Don't miss that. Okay. How about this? Pneumothorax here, the trauma board. So pneumothorax, leftward mediastinal deviation. What could this be? Tension pneumothorax is what you should consider. You can't make the diagnosis. That requires a clinical diagnosis of circulatory compromise, but that's something that you need to raise the possibility. So you need to raise the possibility this could be tension pneumothorax. Okay, let's move on. Pleural effusions. So loculated pleural effusions or pseudotumor is something that you should be aware of and think about. Exudative effusions such as empyema malignant or asbestos effusion. How do you differentiate exudative from transudative effusions? If you see on a contrast-enhanced scan thickened, enhancing pleura, that is consistent with an exudative effusion, meaning could be empyema, could be malignant, could be asbestos-related. Chylothorax, Hounsfield number is usually 0 or near 0. This is a little bit tricky. It's almost impossible to diagnose a chylothorax based on imaging. Okay, it's rarely negative numbers. Okay. Then hemothorax, this one you should be familiar with. You're going to see high density. It could be uniform high density. You can see thrombus in part of the fluid, in part of the pleural fluid, or you can see a hematocrit level on occasion. So what's this? Lung cancer? Well, it looks like it's right along the fissure. This happens to be a loculated pleural fluid collection. Remember that as a possibility. How about this? What's this? Patient who was on anticoagulation. This is a hemothorax. You can see central heterogeneous high density hemothorax. Okay. Let's talk about empyemas. Of course, this means infected pleural effusion with pus. These are some of the common causes: bacterial and tuberculosis. A loculated exudative effusion is common with thickened enhancing pleura, and you can see what's called a split pleural sign. In other words, the pleura is surrounding the effusion. Obviously, it's going to surround the effusion, but if you actually see it, then that suggests that there's thickening of the pleura, and it means it's exudative. So you can see air in an empyema. Why? Because first of all, frequently these patients have undergone thoracentesis or drainage, so there's been instrumentation. But if you see air, you have to be thinking about other things as possibilities, and there are two important causes: bronchopleural fistula and rarely gas-forming organisms. Okay, so don't forget those. If you see air, it's most likely instrumentation. Second most likely cause is bronchopleural fistula. Gas-forming organisms rare, but poor prognosis. Okay, and these are oblong. This is a really, really important point. You need to be able to distinguish intraparenchymal abscess from an empyema. And how do you differentiate that? Because empyemas are oval, they're elongated, they're different. They have a different appearance on the frontal view and the lateral view. Intraparenchymal abscesses tend to be round, so they have the same shape on the frontal and lateral view. And why does it matter? Why do I care whether your diagnosis is empyema or abscess? Because abscesses are not typically drained. They're treated with antibiotics. They drain themselves through the lung, through the airway. Whereas empyemas need to be drained in general. So empyemas and abscesses are treated differently. You need to make that distinction. If you don't make the distinction, you're not doing right by the patient, and you're not doing right by yourself at the boards. Okay. So this is actually it's oblong, isn't it? Even though the appearance is pretty similar on the frontal and lateral view, look how elongated it is. I would think that this is more likely pleural just because it's elongated. If it's elongated in any direction, you're thinking pleural. Why is there an air fluid level? Well, this person could have had an instrumentation, could have had a bronchopleural fistula, or much less likely gas-forming organisms. And this is what it looks like on the CT. You see how elongated it is? It actually it's lobulated, and maybe it could be loculated, but essentially there's an air fluid level elongated, and look at the thickened enhancing pleura. That suggests that it is exudative, and this is the split pleural sign. You see the pleura here, and it's split on either side. So that's an exudative effusion, and this split pleural sign is suggestive of empyema. Okay, let's move on. Pleural neoplasms. So what neoplasms occur in the pleura? Well, metastases frequently go to the pleura from what? Lung cancer, breast cancer, GI tumors, melanoma, and thymomas. Okay, if you see a case, don't just yell out several different diagnoses, but say this could be due to lung cancer, melanoma, breast carcinoma, for example. And thymoma is the drop metastases that I discussed. Lymphoma can also give you pleural neoplasm, or can involve the pleura. And mesothelioma, everyone thinks about this and talks about it, but it's actually not that common. It's strongly associated with asbestos exposure, and if you see involvement of the fissure, in other words, nodules or masses in the fissure, think mesothelioma is more likely than other possibilities. So fissure involvement is more suggestive of mesothelioma. It's not diagnostic, but suggestive. And localized fibrous tumor of the pleura, which is not common and not related to asbestos exposure. How about this particular case? Look at the nodular thickening of the pleura. So this isn't a single mass, it's circumferential, could be mesothelioma, but that's not common. More commonly are metastases from what? Lung cancer, breast cancer, what else? Drop metastases from thymoma, GI tumors like gastric carcinoma, pancreatic carcinoma. And this could also be lymphoma or mesothelioma, as we discussed. So you don't have to mention all of them, mention a couple, say mesothelioma is a possibility, but more likely metastases such as lung cancer or breast cancer. How about this? This is a huge pleural effusion, and we see that pleural mass there. It's actually involving the bone. This turns out to be a renal cell carcinoma with pleural metastases. And a different patient with a gigantic mass in the pleura, which, that one was a lung cancer that had metastasized to the pleura. So let's talk about pleural calcification. So this is most commonly due to asbestos-related pleural disease. And if you see small areas of calcified plaque, in other words, it's bilateral small, and more likely tending to be near the bases, such as laterally or along the diaphragmatic aspect of the pleura, that is characteristic of asbestos-related pleural disease. That is not asbestosis. Patients typically don't have symptoms. This is not asbestosis, and they are not entitled to compensation in the class action lawsuits that have been taking place. So it's important, don't call this asbestosis, it's simply asbestos-related pleural disease, pleural plaques, and calcification. On the other hand, in contrast, calcified fibrothorax is a different type of pleural calcification. It essentially is extensive calcification, and it's unilateral. The hemithorax can be smaller than the opposite side, and it's most commonly due to old hemothorax or empyema, especially tuberculous empyema. So look at an example. Look at the extensive unilateral calcification. Left is completely normal, or virtually normal, the pleura. And on the right, you see that it's smaller, extensive unilateral calcification. This is calcified fibrothorax due to either TB, prior hemothorax. And this is the CT scan appearance. Look at the extensive unilateral calcification. This lung is smaller than the left.
So I'm going to do a few interesting cases now, and just to warn you up front, some of these are potential, typical cases you could see on boards, and some of them are fascinomas, very rare diagnoses, and they're just mixed interminglingly throughout the entire talk. The point of showing some of these cases is to show you some things that are interesting that you don't see very often, and also to round out a few differential diagnoses, since we had to have fairly broad strokes to cover as much material in thoracic imaging as we have thus far. And you're going to get out on time, even though you may see a whole lot of slides in your syllabus. I put in extra things there if you want to review these extra cases on your own. That's totally fine, but I'm not going to try and set a land speed record here to get through all 200 slides that I might have in your syllabus here. Okay, we'll start out with a couple of unknowns first, and I think I'll cover all these unknowns. I'll get at least that far. And one of them I actually moved up, and I'll let you know when I get to that point, just so we cover all the unknowns. So, what serum lab tests? And these are all leading questions. What serum lab test would be helpful? This is a rare diagnosis, a rare location for this diagnosis, but one serum lab test would be useful for making the diagnosis. Anybody have any idea what this is? It's pathognomonic if you've seen it before, but probably quite a few of you have never seen it before. What do you think this pattern is? And if you can characterize it correctly and name the pattern, that should engender a fairly limited differential diagnosis with one entity leading the list. I think it's always important when you're looking at imaging, once in a while you can get towards a histopathologically specific diagnosis, or at least what that lesion is made of, if you can look at the lesion's behavior. So there's clearly abnormal tissue here. Anterior mediastinum, middle mediastinum. What is this tissue doing to structures that are surrounding it that can lead you to a certain conclusion? And sort of a Röntgen classic here, the syndrome and its components. Okay, we'll come back to all these. So all the histories that I'm going to give you are just by way of introduction, but they're all leading, and they all suggest something about what the patient's diagnosis is going to be proven to be. 42-year-old male, acute shortness of breath and pleuritic chest pain, something we see every day in the emergency room. This is his chest radiograph. Think about how you characterize it, and I'd go through how I'd characterize this radiograph. Multiple bilateral areas of subpleural opacity, probably best term consolidation, although you don't see much of an air bronchogram, except maybe down here. Mid and lower lungs, where it predominates, and the opacities, if you characterize them completely, are roughly triangular with the apex cut off, with a truncated apex. That's a pretty suggestive diagnosis or description. Here's the CT scan, really shows the same thing, and I think to a little better advantage that the plain film shows. Subpleural consolidation, when we use that word subpleural, we mean something's out touching the pleura. Peripheral means it's out in the outer third of the lung, maybe it touches the pleura, maybe it doesn't. So subpleural is as peripheral as you can get without being in the pleura. Subpleural consolidation, a little area of cavitation here, again, roughly triangular shaped with the apex cut off facing towards the hilum. And that's a pretty classic description of a pulmonary infarct. This is what his mediastinal windows look like with a nice saddle embolism here. So PE, something we see every day. How good is a chest x-ray, or how worthless is a chest x-ray in PE, depending on how you want to look at it? In the PILPID series, about 84% of chest x-rays had some kind of abnormality on them. And you compare that to patients subsequently proven not to have PE who presented with PE in their differential, 66% had an abnormal chest x-ray. So in general, there's going to be some abnormality on a chest film, but very rarely will you find something that should specifically suggest PE. Infarcts occur in somewhere in 10 to 60% of patients. This 10% number is more of clinical series. This is more of an autopsy series. So if you infarct a lot, maybe that means you're more likely to die from your PE. Who really knows? They tend to be multiple and lower lobes where the blood flow is. So that makes sense. Initially, an infarct is a fairly ill-defined process, and then over days or weeks, it'll become progressively more well-defined. In the era before CT, this actually mattered a lot on a chest radiograph where you'd retrospectively make the diagnosis of PE. Now with a CT scan obtained at the drop of a hat, this is more of a historical interest. Cavitation may occur in infarcts. It's said to be more common in upper lobes. That's older literature. I don't know if I really buy that. Infarcts that are large, or if they're superinfected. And once they're superinfected, it's either a septic emboli or it's an infarct that got superinfected when it was already in the lung, had already occurred in the lung. At that point, the infection matters more than the infarct itself. The Hampton's hump is neither sensitive nor specific for PE. It's a suggestive opacity when you see it on a chest radiograph, but if you go actively looking for this, you're going to have a lot more false positives than you are true positives. Tends to not have an air bronchogram, and there are other opacities you'll get on a chest radiograph in the setting of PE. Sometimes you'll see pulmonary hemorrhage, and that can look a little bit like an infarct, but it tends to go away in a few days. A true infarct is going to take months to go away. And it's said to melt like an ice cube. Instead of breaking up irregularly like a pneumonia does, it shrinks from the outside in. And it tends to either leave nothing in its wake or a little scar. This is a patient who had a PE. You can see in the right lower lobe artery here with a pretty characteristic subpleural infarct, again, kind of rounded or triangular with an apex cut off facing towards the hilum. Months later, the PE is gone, the effusion's decreased. You can see the thing just shrank from the outside in. Pneumonia usually breaks up with irregular dissolution. So this is pretty characteristic behavior of an infarct. 51-year-old female with cough. Give you a second to make the abnormality here. We'll talk about this extensively tonight, differential diagnosis of the solitary pulmonary nodule. I mentioned some things earlier today we have to think about. We often go to CT scan. Usually the first thing is you're going to look for old films. Patient's got an old film, this thing's been there for 10 years, no problem. You never know what it is, but it's benign. If you don't have old films, we go to CT for characterization, and this is one of the things you hope to find on CT. Thin section imaging, which on single slice CT, you have to make sure that you check the case or brought the patient back. With multi-slice CT, you can protocol your cases so you can get retrospective thin section images right then and not have to bring the patient back. When you do that, you can characterize the nodule, and you see a little bit of fat here. This actually measured negative 80 Hounsfield units when I measured it out. That's pretty characteristic of hamartoma. Third most common cause, at least in surgical series, of solitary pulmonary nodules. It's a mixture of connective tissue and cartilage and some other mesenchymal elements like bone and fat and smooth muscle and marrow and all kinds of other stuff. And in the range of 54% in one study, and the study that I've quoted already and will quote again, it was actually as high as 58 or 59%, may actually show fat. 47 lesions studied at Hopkins in the 80s. 38% had fat only, 21% had fat and calcium. and 4% had calcification only. Again, like I mentioned before, that calcification may have a chondroid pattern, and I'll show you a lesion like that shortly. Here's pretty typical chondroid pattern right here. The AFIP people call this chondroid lesion, like when you see it in bones, same when you see it in a lung nodule, rings and arcs. I think that's pretty useful way to remember the descriptor here. Calcification is often popcorn in configuration. That's what chondroid matrix looks like. It's not that common when the lesions are small. When the lesions get bigger, they're more likely to show calcification. In one study, 75% of lesions that were bigger, like that giant hamartoma I showed you earlier, show evidence of calcification, which is often in that specific chondroid pattern. And don't be surprised if a hamartoma grows. So when you're following nodules over time, if you're looking for growth as one of the markers for an intervention, that doesn't mean you're going to get nothing but malignant diagnoses when you look for growth. Hamartomas will grow over time too. Usually not fast, but you can see growth in them. 62-year-old female with progressive shortness of breath. Here's her chest radiograph. This is one of the reasons high-res CT took off is, do you want to call this reticular, nodular, reticulonodular? Who knows? Pick something and work with it, and as long as you can justify it by pointing to a linear or nodular element on the chest radiograph, then you're right. Get 3 people in the room and you'll have 3 different ways of looking at the radiograph. I see a lot of linear elements and reticular elements in here, and of course where lines cross, they can create the appearance of nodules. That's why it's so nonspecific. I think one of the important things to recognize is that the lung volumes are relatively maintained. This looks like an interstitial appearing radiograph. And a lot of things that infiltrate the interstitial, particularly that are linear and reticular, tend to be restrictive. They tend to restrict lung volumes and make the lung volumes small. So it's somewhat peculiar that these lung volumes are well maintained. That may just mean that there's obstructive disease on top of it. That's the one pitfall. But once in a while, it may make you think that you're dealing with something funny, like maybe a weird case of sarcoid or something like that. This does not look upper lobe predominant like sarcoid would be. But it certainly doesn't look like usual interstitial pneumonia either. Those lungs are usually far more physiologically restricted. Here's a patient's CT scan. So Rick went over this, and I'll go over it again. Look at an HRCT image. The dominant opacity that you're seeing here is an area of increased opacity that's very small. It's a nodule. We see nodules, we want to characterize them according to their distribution with regard to the secondary lobule, as well as in the lung in general, upper, mid, and lower, middle third, inner third, outer third, that sort of thing. You look at these nodules, like Rick mentioned in his talk, and I'll mention as well, you can see these nodules are touching the costal pleura, and they're all along the physeal pleura as well. So you know right off the bat that this is not going to be a centrilobular predominant process. This is going to be perilymphatic, or it's going to be random. We want to differentiate perilymphatic and random. Random is usually widely disseminated, upper, mid, and lower lungs affected, anterior, posterior, middle, inner, outer third, all relatively similarly affected. Perilymphatic processes are patchy. Some areas are abnormal, other areas not so abnormal. This is a fairly patchy process. Less abnormal here, more abnormal there. That usually puts you in that area of sarcoidosis. That's probably the leading differential diagnosis for a perilymphatic nodule in the proper clinical setting. The other disease I mentioned in one of my talks earlier, lymphangitic spread of carcinoma. This is neither of those. It's going to be one of those weird ones. Help round out your differential. Multiple small nodules. Note how they're all along bronchovascular bundles as well too. You see a little nodule here right on that bronchus. Lots of nodules here along the costal pleura, along the physeal pleural surface. And in the end, this was actually amyloidosis. It's a pretty rare diagnosis. There are really 3 forms. When you're thinking about amyloid and you're wondering how can you get a handle on this disease, really 3 major ways you see in the lung. It's rare any way you look at it. Tracheobronchial, probably the most common way you'll come across amyloid in the lung. Nodular parenchymal, and I show you the example of that, just a big mass in the lung. Often it'll have a little bit of calcium in it, but it's not specific. And then alveolar septal, and it's neither in the alveoli and not always in the septa, so it's a bad name, but this is what's in the literature. And it's the least common variety, but that's what you have here, alveolar septal amyloidosis. To be very precise in this case, it was actually light chain deposition disease, which is a form of amyloid, really. Tracheobronchial amyloid, usually the patients don't have other stuff in the lung. So you're going to see an abnormality of the airways. And Gautam might have alluded to some of that in his airway talk. Don't expect to find things in the lung in those cases. Manifestations in the airway when you come across it, a focal mass with or without calcium, so-called amyloidoma. So just a lesion sitting in the trachea, it looks like a cancer. A diffuse form, which is probably what you see more often in the literature and probably in real life as well, that can cause concentric airway thickening that involves the posterior membrane as well and often calcifies. Here's the amyloidoma right here. This actually had a little bit of calcium on soft tissue windows. suggesting that it's benign, but there was a significant non-calcified component, so we didn't know for sure. Had to biopsy it, didn't get a specific biopsy answer, so it got resected. That's how it was proven to be amyloid. Tracheobronchial amyloid, you can see a little airway thickening with calcification here, and if that thickening is pronounced enough, you'll actually get an airway stenosis. This is usually a fairly diffuse process. It may go all the way up into the subglottic trachea and down into the main stem and lobar bronchi. Differential diagnosis, in this particular case, relapsing polychondritis would be in the differential diagnosis. There are ways of differentiating these diseases. Wegener's granulomatosis, tracheobronchopathia, osteochondroplastica. Here's another case of tracheobronchial amyloid. This one was proven on bronch. You can see how nodular, plaque-like thickening you see in the trachea, not causing a critical stenosis. The airway's not horribly narrowed here. The lobar bronchi are. And you can see little areas of calcification. Amyloid almost always has some areas of calcification or ossification, and it doesn't necessarily spare the posterior membrane. Relapsing polychondritis will tend to spare the posterior membrane, may calcify a little bit now and again. Wegener's granulomatosis can look very similar to this. Alveolar septal amyloid, you'll see very small nodules. It looks a lot like sarcoids, so they're peribronchial vascular or perilymphatic in distribution, but they calcify rather densely. And when they conglomerate together, you may see large masses and areas of heavily calcified consolidation. Also infiltrates the septa somewhat, so you'll see a little bit of intralobular septal thickening and some crisscrossing lines. And it does cause a restricted disease that clinically somewhat simulates sarcoidosis. So radiographically there are similarities, and clinically there are similarities. This is a patient that went on to lung transplantation due to diffuse amyloidosis, and it's a good example of what perilymphatic nodules look like. You can see very large nodules. This is a long interlobular septa, a series of septa kind of strung together. You can see a little septum right here, a little septum right there. These nodules are sitting right on the septa, so it's characteristic of a perilymphatic process. And in this case, they're calcified, and you get areas of conglomeration of the amyloid will give you areas of calcification as well. 54-year-old male with general malaise, urinary frequency, and weakness. This is the first unknown case, and that's a very leading history for this particular diagnosis. What laboratory tests would be most helpful? This is a very enhancing lesion in the mediastinum. Most thymic neoplasms don't enhance this much. They can have elements enhance this much. Thymic carcinoid is one neoplasm that may enhance like this. A paraganglioma in the mediastinum, glomus tumor in the mediastinum could enhance like this. Turns out serum calcium was up in this patient. This is a parathyroid adenoma, and this is one of the rare locations for an ectopic parathyroid adenoma. Patient had hyperparathyroidism, and hypercalcemia tends to cause those symptoms I outlined. Typical etiologies, adenoma overwhelmingly the most common cause, usually a single adenoma that may be in the characteristic location where parathyroid glands live, or it could be ectopic. Multiple adenomas seen in a small number of cases. You may see hyperplasia, particularly in end-stage renal patients, and then very rare cases of parathyroid carcinoma. It's a very rare diagnosis. Most patients will have 4 parathyroid glands. Typically, the superior parathyroid glands are located along about the mid-body of the thyroid, right behind the thyroid gland. Most patients who have normal parathyroid glands, you won't be able to see them on routine imaging studies. Even high-resolution ultrasound of the neck, they're very hard to find when they're normal. Inferior glands sit along the inferior aspect of the thyroid, so when these glands go bad, this is the area we tend to look for them in. When you see ectopic parathyroid adenomas, where do they tend to live? Probably one of the more common places is in the fat in the anterior mediastinum, right beneath or within the thyrothymic ligament, which is just fat connecting the undersurface of the thyroid towards the thymus in the anterior mediastinum. That's actually where the parathyroid glands embryologically are making their motion in their ascent or descent, depending on how you look at it. And so they arrest anywhere along that line of motion, they're going to sit in that fat right there. You may see them in the posterior mediastinum. May actually occur in the thyroid gland itself. So a hypercalcemic patient with a thyroid nodule, you got to think about parathyroid adenoma. It can even occur in the carotid sheath, so they can mimic a paraganglioma when they're sitting up in the region of a carotid body tumor. You may see them in the tracheoesophageal groove or rectopharyngeal, or even in the anterior mediastinum. This case that I showed you is probably more properly termed thyrothymic ligament. I'll show you an actual mediastinal lesion shortly. This is a pretty typical case of parathyroid adenoma, what they look like on imaging. Most people are not undergoing CT, although some people will talk about multi-site CT for this diagnosis. Usually it's a high-resolution ultrasound diagnosis where a patient presents with hypercalcemia, surgeon asks for an ultrasound just to see which side it's on, and then they go explore that side that you find the nodule on. They didn't really care if it's parathyroid adenoma you found, they just want to know what side's abnormal. They explore that side and take out 2 of the parathyroid glands. That's one way that a lot of people approach it. Patient still has recurrent or persistent hyperparathyroidism after surgery, then you go hunting for the ectopic glands. So this is a typical normal location of a parathyroid adenoma, right behind the thyroid gland, just medial to the carotid artery and jugular vein. Here's a retropharyngeal parathyroid adenoma. They're usually ISO to decreased signal intensity on MR, usually showing increased T2, so low, intermediate to low T1, increased T2 signal, often even brighter than this one. And they're very vascular lesions. So on MR and CT, they enhance like crazy. And you can see this one enhancing pretty well in the retropharyngeal space.